Welcome everyone to our 293rd University of Best Practices since we started the Right Care Initiative. We are going to be focusing today on some really important lifestyle aspects of protecting our cardiovascular health and reducing metabolic disease. With that, I'd like to thank our wonderful sponsors from the California Department of Public Health, the Los Angeles Department of Public Health, Blue Shield of California, the Stroke Awareness Foundation, the California chapter of the American College of Cardiology, our wonderful academic partners, including the University of Southern California, University of California, multiple campuses from San Francisco to Irvine, Davis, UCLA, UC San Diego. It's a wonderful collaborative across the state, including Stanford University. And we have wonderful support from the Santa Clara Health Trust, doing some very innovative things with the community clinics of Santa Clara County. We also are so grateful to the scientists in the biopharmaceutical world that support our health and the innovations that have developed the vaccine. We want to thank our longtime partners, Johnson & Johnson, Genentech, Novo Nordisk, Boehringer Ingelheim, Amarin, and Amgen, and especially want to thank our wonderful volunteer experts that join us from around the state and increasingly around the country now that we've gone to Zoom. Next slide, please. Most of you already know me, and I've been working in clinical quality improvement both from the legislative standpoint and in government health policy, and now through UC Berkeley School of Public Health, really since I graduated in 1991 from the Kennedy School of Government, where I focused on health policy and quality improvement. Next slide, please. I want to call out a special thank you to the wonderful, my wonderful co-founder of this project, Warren Barnes, who was the former chief lawyer of the Department of Managed Healthcare, and he wrote most of the laws that undergird the legal environment in California, which is really quite strong. He and I worked together on the right to second opinion, the right to mental health parity, many other wonderful aspects of creating a healthier clinical quality improvement environment for our patients of California. And when we started our very first University of Best Practices, some of the medical directors in the room that we had gathered said, is it legal for us to be gathering and talking about quality improvement? And Warren Barnes was there to reassure everyone that we compete against disease and not each other in the Right Care Initiative. And there, with that, I'd like to say that he and I had a lovely discussion a couple of days ago. He's doing well, but he couldn't join us today. Next slide, please. I'd like to introduce those of you who don't yet know our wonderful chairman, cardiologist Bill Baumer from UC Davis. He has trained many of the cardiologists in California and does so much public good. It's hard to even list all the great things that he's doing, not only in the Right Care Initiative, but beyond. So he is our statewide chairman of all of our University of Best Practices. And he works with me on the National Hypertension Roundtable with the Centers for Disease Control. He does significant legal oversight, regulatory oversight work with the state of California, and is very helpful to many of the hospitals around the state in improving their surgical programs for better outcomes for patients. So you see that he has a multitude of awards and papers and honors, and is really quite a phenom, and we're just so grateful to have him with us. So Mr. Physics, Mr. Bill Baumer, Chairman Bill Baumer, I'm going to hand the facilitation of the meeting off to you, and thank you so much for being with us and for your passion for improving patient outcomes over the many years and leading our effort.
Thank you very much, Hattie, for that. We are here to talk a little bit about some important aspects of clinical quality improvement for the vast majority of individuals who are at risk for cardiovascular disease. Before I enter that, I want to just quickly review a little bit what we've spent the last year and a half talking about to some extent, which was COVID-19. I have, for the first time, I would say in almost 2 years, some pretty good news for COVID. I would say the last meeting, we were sort of at the peak of the fourth wave. The good news is we're almost halfway down in the event rate, mortality, and hospitalizations and new cases for the fourth wave of COVID-19. So that's good news because for two reasons. One is we're on the downslope of the curve, number one. We do have more people vaccinated, perhaps as much as 65% of eligible adults for it. Children 5 to 11 will probably be approved in the next week or so for immunizations. So that will, or vaccinations, that will give us another 20, 25,000 or million individuals vaccinated. So we're starting to get there. So the good news is the severe cases of COVID with vaccination and with, I believe, prior infection. Because this last round of Delta virus has infected a lot of the people who were not vaccinated. So they actually pick up some immunity, not as good as with a vaccination, but they pick up some immunity from that. So based on the fact of more endemic cases of it with exposure to it and the higher level of vaccination, we're starting to get a lot of people vaccinated. Now, will we get to, the bad news is, will we get to herd immunity so that this disappears from the US? I think the answer to that is no, we will not achieve that, and we will not eliminate coronavirus, the SARS-2, from our population. And the reason is, even vaccinated people are picking up so-called breakthrough infections and are able to carry it for a period of time and then pass it on to someone else. So we will have probably coronavirus, SARS-CoV-2 or COVID-19 with us perhaps indefinitely at this point in time, especially since much of the world is unvaccinated. It will continue to circulate in those populations for time to time. The good news is it will develop in the US like what the regular corona colds are. These are episodes of virus that circulate from year to year, but don't seem to kill people because of hopefully our prior exposure, preventing it from becoming serious disease, pneumonia, and death from it. So it is with us this day, hopefully as a less severe course than we have sustained in the last year and a half to 2 years for that. Now, that being the case, that it will gradually go down from pandemic level to endemic level, we are still faced with our significant highest risk, and that is for cardiovascular disease. And that is what California Right Care Initiative is focused on. The goals are to actually drive to zero preventable heart disease, strokes, and diabetic complications for that. through the best possible education, screening, diagnosis, and outreach for our individuals for that. We do know that it's fairly easily preventable. Risk factors have been identified in multiple trials. And so if we achieve control of high blood pressure at a high level, control of diabetes in those individuals as well, and control of cholesterol, specifically LDL cholesterol, this would go a long way in reducing it. And studies have shown if we eliminate all risk factors for atherosclerotic disease, we can significantly reduce this disease. In fact, the attributable risk from these known risk factors is in the order of 90%. So we eliminate them, we could potentially drive to zero or close to zero by eliminating 90% of these preventable events. And that's the goal of the Right Care Initiative for that through a variety of things, including today's program, University of Best Practices, where we're going to have a fascinating discussion about nutrition and sleep and how those play an important role. So the program today is shown here, and we'll be talking about dietary strategies for risk reduction with Geeta Sikand, and we'll also be talking about sleep quality, which also relates to stress with Major Jeffrey Smith for that. Next slide. So again, just to review our programs that we have been publishing for years to reduce or get to zero the risk of disease. It does include patient activation, stress reduction, including healthy sleep, which we'll go over today, including nutrition, which we'll go over today, and physical activity, which we went over 2 sessions before on that. Smoking cessation is obviously part of it as well. We focus on the clinical team. On the left of the triangle, you see how pharmacists are a critical part of that team, as well as the California Department of Public Health and other government agencies. And we do cooperate with the Surgeon General and do have a call to action, which was initiated under our watch on hypertension control for that. Obviously, it's patient-centered. We have an outreach program, and we have different protocols. We typically look at national endorsed guidelines by national agencies based either in the US or Europe or globally for doing that, because these are well thought out and well-reasoned guidelines for reducing cardiovascular disease. Next slide. So our first speaker today on nutrition is going to be giving us fascinating information about that. Geeta Sikand is shown here, is an associate clinical professor at UC Irvine. She's director of nutrition and the preventative cardiology program at UC Irvine. She's a registered dietitian, nutritionist, clinical lipid specialist, and fellow of the National Lipid Association. Her CV is summarized here briefly, and you can see that it's extensive, both based on her positions, as well as her publications, all relating to lipids, nutrition, etc. She has served on multiple committees and received multiple awards as outstanding dietitian, has been an officer in many of the national organizations for that. She received her master's in nutrition from California State, Long Beach. And what I like to show here is she loves to present workshops and lectures in cardiovascular nutrition, which is exactly what she's going to be doing today. So Geeta, welcome to our program, and we look forward to your presentation.
Thank you very much, William, for that very generous introduction. I'm super excited. Let me just share my screen. Okay, so as I said, I'm super excited to be here to speak with all of you. I really am amazed at this forming of this Right Care Initiative University. I'm really pleased to be here. So in the interest of time, let's begin.
Geeta, if we could just go to your full screen.
Yes, okay, thank you for the reminder.
Perfect.
Okay, so our topics of discussion today are the top 10 dietary strategies and the current national recommendations for ASCVD risk reduction. We'll also review the scientific evidence to address recent controversies related to dietary patterns, saturated fats, omega-6 polyfats, dietary cholesterol and eggs, ketogenic diets, intermittent fasting, and then red meat and processed meat. And we'll also review the evidence that supports the clinical and cost benefit of medical nutrition therapy, which is multiple visits with a dietitian in patients with both dyslipidemia and or cardiometabolic risk factors. And since we are the Right Care Initiative, we believe in evidence-based, so I'm going to share those with you. So as we know, globally, poor dietary quality has surpassed all other mortality risk factors associated with 11 million deaths annually, and half of these deaths are attributed to cardiovascular disease. In this slide, we can see, if we look at the center of the slide, the healthy diet score that was published by Benjamin in Circulation in 2019. And we can see for United States, less than 1% of adults came up with an ideal healthy diet score, which is the green. And as you can see here, you can barely see that green color. You can only see the big reds, which means poor diet score. And the yellow means moderate or fair. And then green is the ideal diet score. So that's pretty disappointing. And so when Angel published his 2020 AHA advisory article on the 2030 impact goals, he talked about, and the whole team talked about, the estimated costs because CVD is the leading cause of death among several racial and ethnic groups. Over $200 billion a year in healthcare services, medications, and lost productivity. So the AHA goal is to promote a healthy lifestyle throughout life to prevent ASCVD, heart failure, and AFib. So in the same article, Angel et al., they published, they said the most important way to prevent ASCVD, heart failure, and AFib are to promote an ongoing healthy lifestyle, which includes a healthy dietary pattern. And the healthy dietary pattern emphasizes the plant-based foods, such as vegetables, fruits, nuts, legumes, pulses, whole grains, low-fat or non-fat dairy, lean sources of vegetable or animal protein, and fish. And also minimizes the intake of trans fats, saturated fats, processed meats, refined carbs, and sugar-sweetened beverages. So with that background, let's see what the 2019 ACC-AHA guidelines said. They came out in 2019 as well. And they reminded us that healthcare providers should consider the whole person by using shared decision-making and making the patient understand their concerns and understanding their concerns back to us. Using team-based care, such as referring patients to specialists, such as registered dietitian, nutritionists, psychologists, and physical therapists when practical. And understanding the social determinants of health. Example, patients' willingness and ability to make lifestyle changes, which is one of the first things we do as dietitians. When we see our patients, we definitely gauge that. And we also look at their health literacy, socioeconomic status, neighborhoods they live in, and social support, among others. So in 2020, two of us, myself and Tracy Severson, both registered dietitians, we published this paper, Top 10 Dietary Strategies for ASCVD Risk Reduction. in the American Journal of Preventive Cardiology. And I will review these top 10 strategies, and then we'll go into the dietary controversies. So the first one is to incorporate nutrition screening into medical visits. And for that, there is a article, I'm sorry, let me just turn that off.
Well, while she's handling that, I'll just say that it's wonderful to have the National Lipid Association promoting dietary change as a way to control lipids, and we're all learning more and more about this every day. Love your slides, Geeta, and don't worry about that little interruption.
And the fourth, getting back to the second one is to refer patients to the RDN for medical nutrition therapy when appropriate for improving cardiometabolic risk factors, and to follow the ACC-AHA dietary recommendations for ASCVD prevention and management of these particular cardiometabolic risk factors: overweight, obesity, type 2 diabetes, and hypertension. The fourth one is to utilize the NLA nutrition goals for optimizing LDL and non-HDL cholesterol. Number 5, to utilize evidence-based heart-healthy eating patterns for improving cardiometabolic risk factors. This is more like a laundry list, but then we'll get into the nitty-gritties in just a bit. To implement the ACC-AHA NLA nutrition and lifestyle recommendations, and also for optimizing triglyceride levels. The number 7 is understand the impact of saturated fats, trans fats, omega-3s, omega-6, monounsaturated fats on ASCVD risk. 8, to limit the dietary cholesterol for those with dyslipidemia, diabetes, and at risk for heart failure. To include dietary adjuncts such as viscous fiber and plant sterols and stanols. And lastly, to integrate ACC-AHA NLA physical activity recommendations. So with that, we'll dig a little deeper into these. So the first one on incorporating nutrition screening into medical visits. So all healthcare providers might want to consider doing this at the point of care as recommended by the AHA. And this was a wonderful paper published by Valdevalu et al. In AHA Advisory 2020 in Circulation. And the paper was all about rapid dietary assessment screening tools for CVD risk reduction. As you can see here, they reviewed 15 tools, of which 3 met the most theoretical and practice-based validity criteria. And so you may want to dig deeper into these if you decide you want these as part of your evidence-based practice. The second one on referral criteria for medical nutrition therapy, we went with what the Academy of Nutrition and Dietetics recommends, and the NLA also recommends, which is excess weight. So if BMI is greater than 24.9, up to all the 3 classifications of obesity, as you can see, or the abdominal obesity, which is the waist circumference we go by. And in South Asians, it's different. In South Asians, it's more like 35 and 31 instead of 40 and 35 for men and women, respectively. Also, abnormal lipids, uncontrolled hypertension, poorly controlled diabetes, and pre-diabetes. Then moving forward, I'd like to share this information. This is evidence-based. We conducted a systematic review and meta-analysis and published in the Journal of Clinical Lipidology in 2018, where we looked at the clinical and cost benefits of medical nutrition therapy by the dietitian for management of dyslipidemia. And you can see we have a nice long team of authors. Okay, so this is a summary slide where you can see that we looked at 34 primary studies, over 5,700 participants. It also included 10 randomized controlled trials. So about half the participants, over 2,500, were from the RCT database. We looked at face-to-face dietary counseling or medical nutrition therapy, and we examined both cardiometabolic risk factors and the cost savings. And the results are noted here. Total cholesterol was reduced by 9.9 milligrams per deciliter, LDL by 10.3, triglycerides 15.9, A1C almost half a percentage point, glucose 50.53 milligrams per deciliter. This should actually be 53 milligrams per deciliter. And body mass index went down by 0.39. So again, almost half a point. And the HDL was not significant, and although it shows there was a slight increase, but all of these were statistically significant and clinically significant. The quality of life years increased by 10.75, and there was a reduction in medication costs, which amounted to, per patient per year, $638 to $1,456. And this was done back in 1990s. So you can see that that dollar value will be much higher now. So the conclusion was that evidence from this review and meta-analysis demonstrates that multiple MNT sessions by an RDN are clinically effective and cost beneficial in patients with dyslipidemia and cardiometabolic risk factors. Now I'd like to share with you the, just move this panel away, the actual forest plot curves, where you can see from this meta-analysis that when we examine the LDL cholesterol based on the RCTs, the randomized controlled trials, so you can see here, anything that left of zero favors intervention, and anything on the right of the zero favors control groups. So no intervention. So you can see here that this was a very statistically significant finding, that LDL cholesterol dropped by 10.3 points. And for triglycerides, they dropped by 16 milligrams per deciliter, and this was based on 1,800 participants. And when we examined for patients, their A1C scores, you can see again, all the studies are left of the zero. So again, it favored medical nutrition therapy by the dietitian as opposed to the controls. In this one, we can see BMI changes. And again, here's the zero line. And majority of the studies are on the left, which means it favored intervention. And again, this is blood pressure. And we can see again, here's the zero. And everything, most of the studies on the left, except for the one. And here again, we can see the same. Okay, so again, the study concluded that medical nutrition therapy by registered dietitians is effective for dyslipidemia, and multiple individual sessions were clinically and cost beneficial. Dietitian intervention led to improved lipids, glucose, weight, and blood pressure, and led to reductions in need for lipid-lowering medications. And these benefits were also reported when dietitian was part of a multidisciplinary healthcare team. So this is our multidisciplinary health. Yes?
Geeta, I'm very sorry to interrupt you, but it doesn't seem like your slides are advancing for the rest of us. We're still back on LDL cholesterol and triglycerides. Shall we have Jenny share your slides and she can advance them?
Resume share. Okay, let me just make sure. Okay, hold on. Let me see. Just check with you. Are they advancing or going back now?
They are advancing.
Okay,
so if you
working.
could go back to, so you said blood pressure, but we didn't see blood pressure. If we could look at that one.
So this was the LDL cholesterol and triglycerides. Did you get to see that?
Yeah, we got that.
That's the last slide we saw, yeah.
Just the blood pressure. Is that what you said, Hattie?
Let's spend some time on this slide. Thank you.
Yes. So here we go with the blood pressure. And as you can see here with the systolic blood pressure, again, it's left of the zero, all the studies, and also for the diastolic. So pretty good data to support all of these conclusions that I had said earlier. So thank you, Hattie, for letting me know we were having trouble with advancing. So the study concluded that medical nutrition therapy is effective for both dyslipidemia and cardiometabolic risk factors. Multiple individual sessions were clinically and cost beneficial, and dietitian intervention led to improved lipids, glucose, weight, and blood pressure. And again, dietitian intervention led to reductions in need for lipid-lowering medications, and benefits were also reported when dietitians were part of a multidisciplinary healthcare team. And so now I wanted to share with you what we do at the University of California, Irvine. We have a multidisciplinary healthcare team in which we take patients who are coming to us for both primary or secondary prevention of heart disease. So this is a minimum of a 4-month program where they see the preventive cardiologist, the registered dietitian, and the exercise physiologist once a month for 4 months. And at that point, they can keep going if they have more to go, more work to do, or they can go to a maintenance program at that point if they have reached their goals. So moving forward here, now we'll get into the controversies. So the first one is, the typical patient walks in and says, which dietary pattern is best for preventing my cardiovascular disease? Is it DASH? Is it Mediterranean? Is it plant-based, vegetarian, vegan? Typical question. So first of all, we go to the 2020-25 Dietary Guidelines for Americans Committee report, and the systematic review they conducted showed strong, consistent evidence that dietary patterns associated with a decreased risk of CVD include higher consumption of vegetables, fruits, whole grains, low-fat dairy, seafood, nuts, legumes, and lower consumption of red and processed meat, lower intakes of refined grains, and lower sugar-sweetened foods and beverages versus the less healthy patterns. And it was strong evidence. But when it comes to going shopping, patients don't go to the store to buy saturated fats or polyunsaturated fats, right? They eat diets or dietary patterns. So each patient's dietary pattern is more representative of their food and nutrient intake versus individual foods. So we really look for the big picture of how we eat and how our patients eat. So this was a great study by Sean et al. It was a wonderful study because it helped us see the association between healthy eating patterns and risk of cardiovascular disease. So in this study, what they did is they looked at the Healthy Eating Index 2015, which is similar to the USDA diet, or they also looked at alternate Mediterranean diet score. They looked at Healthy Plant-Based Diet Index, and they also looked at the alternate Healthy Eating Index, which is the AHA or American Heart Association diet. The commonality in all 4 of these patterns is that they're all high in vegetables, fruits, whole grains, unsaturated fats, and they're low in saturated fats, sodium, and added sugars. And they looked at the cohorts from the Nurses Health Study 1, the Nurses Health Study 2, and the Health Professionals Follow-Up Study. And let's take a look at the results now. So in this slide, we can see the results of the study. And as we can see here, the pooled hazard ratio, as you can see for CVD, for 4 of these dietary patterns, all 4 is beautiful. It's 20% risk reduction here, 10% here with the AMED or the alternate Mediterranean diet. The Healthy Plant Diet Index was 14% reduction. The alternate Healthy Eating Index was 19% reduction. And the same applies to the coronary heart disease and to the stroke, as you can see here. And then here you can see it individually for each cohort, that you can see how risk reduction is taking place. So basically all 4 dietary patterns did great in terms of giving us good outcomes. So this was a new paper that just came out by Choi et al. And I think Jamal Rana is also a co-author, and he's part of our group here, right? So this study is very recent, and it showed that plant-centered diet and risk of incident cardiovascular disease from young, which is youth from say 18 to 30-year-olds to adulthood. Let's take a look what happened. 32-year prospective cohort study followed nearly 5,000 young adults between 18 and 30 years at baseline and evaluated consumption of a plant-centered high-quality diet that also incorporated small amounts of lean animal products. What were the findings? 52% lower risk of incident CVD. Again, this was highest versus the lowest quintile of plant-centered diet quality. And complete exclusion of animal foods from the diet is not necessary according to this study. And of course, we need more studies. The results support a recommendation for the consumption of a nutritious plant-based diet that can allow small amounts of animal foods. So that was very exciting study, just came out. But again, when it comes to our patients, let's look at how it goes in terms of counseling them. So here's Jane. She comes in, she's 48 years old, Hispanic ethnicity, hypertension, dyslipidemia, type 2 diabetes, anxiety, BMI 32, so she's overweight, LDL, because she has diabetes, we want her at least under 70. Triglycerides are high, A1C is high. And she's also a caregiver to her 90-year-old mother, her own mother. So what does she eat? She eats pre-made food, cereals, sandwiches, frozen dinners. So what kind of approach are we going to take for her? Well, at a glance, we can see that she would need a personalized eating pattern, more good fat from plant foods such as avocados, nuts, low fat or non-fat dairy, fish, eggs, lean poultry, avoid fatty red meat. Energy intake has to be managed to support her weight loss. So with that, now which dietary pattern are we going to select for her, or is she going to select for herself? So here we can see that the best data supports DASH diet for hypertension and Mediterranean for high triglycerides and plant foods diet for LDL cholesterol. So it can't be that we tell her, okay, Monday, let's do DASH, Tuesday, Mediterranean, and Wednesday, plant foods. We have to find an individualized diet where we are fusing all these meal plans together. So we're going to examine the patient's food allergies, food preferences, food intolerances, her food budget, her food insecurities, if any, ethnic foods, weight history, previous attempts at weight loss, how many times has she tried and been either successful or failed, physical activity level. So no matter what, we have to individualize because we know giving a sheet is not going to work. So the best eating pattern is the one that our patient will follow. So my take home to you here is that if you are not an RDN, then refer to one if possible, because we can provide that knowledge, support, and positive outcomes. Now let's look at controversy 2, eggs and dietary cholesterol. So the typical patient provider scenario, I heard dietary cholesterol does not matter, but then I heard it did. So how many eggs can I have a week? Can I eat as many as I want? So let's first look at this study that was published, and then we'll talk about some other guidelines from the authorities. So in this study, Wang looked at over 29,000 participants from 6 prospective cohorts in the United States with a median follow-up of 17 years. They subgrouped them into those who ate 3 to 4 eggs per week. So their average cholesterol intake came to 295 milligrams per day, so under 300. And the incident CVD, so they looked at with the adjusted hazard ratio, and you can see here, it was hardly any change. So 3 to 4 eggs a week are fine, right? According to this outcome. And all-cause mortality also didn't change much. So this is great data for patients who eat 3 to 4 eggs per week. Now, when it was compared with 2 eggs daily versus 3 to 4 eggs weekly, take a look at what happened. It went up to 27% in the hazard ratio when they were consuming 2 eggs daily. And all-cause mortality went up 44% for those that were consuming 2 eggs daily. So the study concluded that higher consumption of dietary cholesterol or eggs was significantly associated with a higher risk of incident CVD and all-cause mortality in a dose-response manner, and especially for stroke. And this article by Dr. Wang was also accompanied by a very nice editorial by Robert Eckel. And he wrote that nutrition research, in contrast with RCTs that compare a drug with placebo, is more difficult for many reasons, including complexities in data gathering and changes in human behavior over time. And the reason he said that was because in this study that we just looked at, we can see that they studied these patients for up to 17 years, but there was only one time they measured the intake of eggs. So we don't know if there were changes in patients' diets over the years. Okay, so moving forward, what are the recommendations on cholesterol from the authorities? So when we look at the National Lipid Association, their last recommendations were 2015, and they recommended reduced cholesterol intake to less than 200 milligrams per day if a patient has dyslipidemia, as in high LDL and non-HDL cholesterol, and also for those with diabetes. Then the 2019 ACCHA guidelines came out, and they cited studies of the benefit of plant versus animal-based protein and concluded a diet containing reduced amounts of cholesterol can be beneficial to decrease ASCVD risk. And then also in 2019, the AHA published their science advisory on eggs and cholesterol in circulation. And they said that healthy people may include up to 1 egg daily, and patients with dyslipidemia, particularly those with diabetes or at risk for heart failure, should be cautious in consuming foods rich in cholesterol. And then in the same paper by Joanne Carson, they also mentioned that there are some exceptions to this recommendation. For example, vegetarians, the lacto-ovo, may include more eggs in their diet in moderation because they're not getting the saturated fat then from all the other meat. And then patients with dyslipidemia, particularly those with diabetes or at risk for heart failure, should be cautious in regularly consuming foods rich in cholesterol. And for elderly normal cholesterolemic patients, given the nutritional benefits and convenience of eggs, up to 2 eggs per day is acceptable within the context of a heart-healthy dietary pattern. And remember, these are normal cholesterolemic patients. Okay, our third controversy is on keto diets. So that's been going on for some time. And so let's look at our patient. She's a female, age 50 years, BMI 35, type 2 diabetes, and A1C 7.5, LDL 90, and wants to try the low-carb keto diet to lose weight. So what are your thoughts, she asks. So, well, if you look at the National Lipid Association recommendations for weight reduction, or the AHA-ACC, they all say that weight loss of 5 to 10% of body weight is generally recommended for overweight obese individuals to lower atherogenic lipoproteins and improve ASCVD risk. So it's not all or none. And they also said that any dietary approach will result in weight loss if energy intake is reduced. Several healthy patterns, example Mediterranean, DASH, USDA, vegetarian, can all be tailored to personal and cultural food preferences and appropriate calorie needs to lose weight. So no doubt the ketogenic diet can be one tool among others for weight loss. And this comes from a paper we published in 2019 by the NLA Scientific Statement. It's on low carb, very low carb, and ketogenic diets. And it was a review article. And these were our conclusion statements. Ketogenic diets may be used safely for 3 weeks to 6 months in carefully screened obese patients. And of course, this is with medical supervision. And benefits are due to significant weight loss and improved triglycerides, blood pressure, A1C, and reduced use or withdrawal of insulin and other medications. Now, what's the Achilles heel of the ketogenic diet? The Achilles heel of the ketogenic diet is, and it has been consistently reported for over 30 years. See, here's my paper from 1988. Then there's a paper from 2019 and 2020, and we're all saying the same thing, that the major problem to be resolved with this diet is the maintenance of this large weight loss. So this ongoing challenge of weight maintenance after a ketogenic diet needs a lot of research and attention. Okay. And also our paper, we went on to recommend that referral to a comprehensive lifestyle intervention program with a multidisciplinary team is reasonable to facilitate weight loss and maintenance of body weight. Okay, third scenario. Now we're going to examine intermittent fasting. So here's a female again, a patient, 50 years old, same BMI 35, diabetic, A1C 7.5, LDL 90. Wants to try intermittent fasting to lose weight. What are your thoughts, she asks? Well, let's take a look at the data. So most animal studies state that there are promising results in the prevention and management of chronic metabolic disease with intermittent fasting. However, the human studies are limited in number and duration, and very few studies are greater than 26 weeks. And just an FYI that there are two types of intermittent fasting. There's the 2 days out of 7 each week, so it's like alternate days. And there's also the time-restricted feeding where patients can eat for 6 hours of the day and fast the rest. So when we look at these studies, it was very interesting that when Reinders and Sutton, they did, these are two review articles, but they came to the same conclusion when it came to continuous energy restriction and intermittent fasting, when we compare the two. For example, both overweight and obese adults lost 3 to 8% of body weight, both again in the intermittent fasting group as well as in the continuous energy restriction group. Also, LDL cholesterol, triglyceride, and fasting glucose, there was a modest reduction in both groups. The driving force behind the improved cardiovascular risk markers was the actual weight loss. So it didn't matter how they lost the weight. But the conclusion was that not enough evidence to recommend intermittent fasting as a weight reduction plan. However, if a patient feels that they can do it, there's no harm in them giving it a try. Okay, next scenario, saturated fat intake. And again, we keep hearing again and again, it's okay, it's not okay from many different studies. So let's tease those out now. So the patient provider scenario, our patient says is butter back, our saturated fat's okay now. So we know, first of all, that that's a settled science that saturated fats raise LDL cholesterol. And how do they do it? The mechanism is they downregulate LDL receptors. And when LDL receptors are downregulated, they can't remove LDL cholesterol. This degree of downregulation of the LDL receptors can vary depending on the patient's cholesterol intake, the variation of saturated fat consumed, and the individual dietary responses, including the food matrix. So the individual dietary responses can be due to personalized nutrition, genetics, but there's this whole new component we now talk about, which is the food matrix. So the definition of food matrix is that it is a physical domain within the food that interacts with its specific constituents, such as nutrients, fiber, phytochemicals, and that provides the functionalities and the behaviors, which are then different from those exhibited by the components in a free state. So when we go back, oh, this is a great article. You can go and read further on this. Let's take a look at the Lee and Sachs studies where they did a great job. They examined the CVD risk associated with the replacement of 5% of calories from saturated fat with 5% from other types of fats. So this was isocaloric substitution. And let's take a look at what happened to the cardiovascular risk. Oops. Okay, so in this slide, we can see that when trans fats replaced saturated fats by equivalent energy intake, you can see here the risk went further up by another 5%. But when monounsaturated fats replaced the saturated fats, the cardiovascular risk decreased by 15%. When polyunsaturated fats were used to replace the saturated fats, the risk was reduced by 25%. However, when carbohydrates from refined starches and sugars were used to replace, the risk went up by 1%. So it's like a cross, either one, they're bad, saturated fats or refined carbs and sugars. And then when carbs were from whole grains, we can see the risk actually went down by 9%, proving that all carbs are not created equal. Okay.
Geeta, before you move away from that slide, would you please re-emphasize which PUFAs you recommend and possibly mention something about coconut oil?
I couldn't hear you well. Could you bring the microphone a little closer?
Oh, let's see. Can you hear me now?
Yeah.
Okay, so it shows a really nice benefit from the polyunsaturated fats.
Exactly.
Could you elaborate a little bit on that, please?
Very good. Yes, Hattie, absolutely. The polyunsaturated, which includes omega-6s, and we'll talk more about those. Okay, so moving forward with Astrup et al.'s analysis, because there was a meta-analysis with saturated fats, and his analysis failed to show an effect of reducing saturated fats on total mortality. As you can see, 0.96 was the relative risk. And also cardiovascular mortality. So his meta-analysis said saturated fats don't matter. They don't make a difference on both total mortality and cardiovascular mortality. But there was a rebuttal written to his meta-analysis by the ACC group of authors, Karen Asprey and Penny Chris Etherton and a whole group of them. And what they said is that the authors failed to consider the relatively short period of time for observing a mortality benefit in the included studies. Then there was another meta-analysis, and this was by Hooper in 2020, 11 RCTs over 53,000 patients. And same thing, it reported reducing saturated fatty acids intake significantly lowered risk of combined cardiovascular events by 21%. You can see RR is 0.79. Cardiovascular events only 8% with moderate quality evidence. Then there was an additional meta-regression analysis that showed greater reductions in saturated fatty acid intake associated with greater reductions in the risk of combined cardiovascular events. So where was the controversy here? No effect was reported of reducing saturated fat intake on non-fatal MI or CHD mortality. So how could that be explained? Well, it could be explained by the small number of these events, only 8% reported, suggesting the analysis was underpowered to detect this benefit. Okay, so there was a wonderful debate in which both Penny Chris Etherton and Dr. Krause were on that as the, as the speakers. So what they said is, Penny's particular paper said, limitations of Hooper meta-analysis are as follows. Failed to report, meta-analysis included one large study. It was the Women's Health Initiative study that randomized subjects to a diet low in total fat, but not saturated fat, thus underestimating the overall effect of saturated fats reduction on CVD incidence and mortality. Because this was a very large study and it didn't even control for saturated fat. So I don't know why they even included it in the Hooper analysis. Then the second fault was they failed to include an important meta-analysis reported in the 2000 AHA Presidential Advisory Report on dietary fats and CVD that supported replacing saturated with polyunsaturated fats. And thirdly, they failed to include the two large US prospective cohort studies that we all know about, the Nurses' Health Study and the Health Professional Follow-Up Study. So very faulty meta-analysis. Okay, then came the Pure study. Well, actually it came before all of these in 2017. And the main thing I want to say about this in the interest of time is that the flaws in this prompted editorials cautioned against applicability in high-income countries, as data was derived primarily from low-income countries. And as you can see up here, in 135,000 subjects, 18 countries, there was an increase in consumption of all fats, including saturated fats. And it showed a neutral association with CVD. But the real reason is because, these are poor countries and they don't have access to medical care in general. So those that are eating all these fats are having good access to medical care, which the study obviously didn't control for. Okay, then moving forward, these are the guidelines from the authorities. As you can see here, ratings to decrease saturated fats. They've been issued by the most recent European Society of Cardiology guidelines, which recommend to replace saturated fat with unsaturated. 2020 dietary guidelines do the same, replace saturated with polyunsaturated especially, but all unsaturated fats. National Lipid Association, they say less than 7% of energy from saturated fats. So with that,
your slides are not forwarding. I'm sorry.
Sorry?
We're on the limitations of the Hooper analysis slide. I don't know what happened.
I could not hear you. I'm sorry.
Can you please forward your slides? We're showing the limitations of the Hooper meta-analysis slide, and I think you're on a different slide.
Okay. You want me to show the meta-analysis?
No, your slides are not advancing. Could you advance your slide?
Oh, they're not. Oh.
They're not keeping up with what you're talking about.
Oh my. Okay.
Okay, so right now I see N equals 135,000.
Yes. Okay, so
good.
that was the pure study I was talking about earlier, in which I said there were 18 countries and 135,000 subjects. And it showed that saturated fats, mono and poly, were all associated with lower death risk. But the reason for this failure was that saturated fats showed the lower death risk was because these were lower income countries. And in these countries, it's people that eat high fats are the ones that have better access to medical care. So therefore, okay. Now I'm going to move up to this, the recommendations from the European Society of Cardiology Guidelines 2021, the 2020 Dietary Guidelines Advisory Committee, and the National Lipid Association. And all of them have made the same recommendation. And that is, it is recommended to replace saturated with unsaturated fats to lower the risk of cardiovascular disease. And look at the grade of evidence, class 1, level A, grade strong. And here again, grade A strong. Okay. Now we're going to go to the next controversy, and that is the red meats and the processed meats. And in this controversy, we can see that it's all about, first of all, the TMAOs, which is our trimethylene nitric oxide, which is associated with increased cardiovascular risk and incident MACE. Also, there is an increased ASCVD risk with abundance of TMA-producing bacteria in the gut. So this is an area we're starting to learn a lot about. And so replacing 2 servings per day of red meat with plant-based protein for 8 weeks significantly reduced TMAOs and LDL cholesterol. And this is our own Stanford study from California, Christopher Gardner's study by Krimarko et al. So very exciting that we can see that. And another area I wanted to talk about was that high intake of both unprocessed and processed red meats are linked to increased both MIs and CVD risk. Because red meat is high in saturated fats, cholesterol, iron, which is the plasma ferritin, the L-carnitine, and the phosphatidylcholine. So again, these are found in red meat and choline in eggs. And these are the major precursors of the TMAOs formed by the gut microbes, the carnitine and the choline. So, as I was saying, this is a very active area of research, TMAO and cardiovascular risk. So here's why. White meat did not increase TMAOs as much as red meat, but then fish consumption increased TMAOs more than beef or eggs. Gut microbiota distribution is what it's about. It plays a huge role in the TMAO response, and the response distribution appears to be quite skewed, as you just saw above. So it's all about the dysbiotic gut microbiota. And how do we know it's dysbiotic? When the ratio of firmicutes to bacteroidetes is high, then these individuals produce greater TMAOs versus lower. So the good guys are the bacteroidetes. We want those to be high, and the firmicutes are the bad guys. And so we want those to be low in order to have lower TMAO levels. And again, as I said, we are still learning a lot about this area. Okay. And again, when we compare processed meats with regular unprocessed red meats, most strongly linked are the processed red meats to CVD risk. And this was a meta-analysis over 1.2 million people. Processed red meat associated with 42% higher CHD risk for each 50-gram serving per day, but no association between unprocessed red meat and CHD. So our next one, our controversy 7, this is our last one, is that omega-6 fatty acids, do they cause inflammation? Well, let's take a look. Does increasing intake of omega-6 polyunsaturated fatty acids lead to increased pro-inflammatory cytokines in humans? And here we're talking about corn oil, safflower, soybean oil, sunflower oil. And what do we find? Well, here's a great paper by Wang and Frank Yu. And we can see in this paper that they clearly showed that there is no clinical evidence that increasing intake of omega-6 fats leads to increased pro-inflammatory cytokines in humans. Higher intake of omega-6 was not associated with inflammatory biomarkers such as CRP, IL-6, soluble TNF receptors 1 and 2 in our previous study, whereas plasma omega-6 was inversely associated with the level of pro-inflammatory interleukin-1 RA and positively associated with anti-inflammatory transforming growth factor beta. So there we go. And the last two slides here are about lowering LDL cholesterol with viscous fiber here, beta-glucans, pectins, gums, and mucilage. What we also call is soluble fiber. The NLA recommends 5 to 10 grams of viscous fiber per day to reduce LDL 4 to 10%. And as we know, the soluble fiber or viscous fiber is found in oats, barley, legumes, lentils, apples, and so on. And of course, you can get supplements such as fiber laxatives that contain psyllium and methyl cellulose. This is just a slide to show you different sources of soluble fiber. And as you can see here, the vegetarian baked beans have 12.6 total, and almost half of that is soluble fiber. Kidney beans, 11, and almost half is soluble fiber. So it's not hard to get that 5 to 10 grams of viscous or soluble fiber if you enjoy eating beans. And of course, there's so many other sources here for you. Okay, now plant sterols and stanols also help to lower LDL cholesterol. The National Lipid Association also recommends 2 grams per day sterols and stanols because that lowers LDL 4 to 10%. And that's usually found in vegetable oils, nuts, seeds, and grains. But it's very difficult to get it from food sources because in the typical US diet, it's 200 to 400 milligrams per day. In the vegan diet, it's double, 400 to 800, but it's not 2 grams. So to get 2 grams, it would be helpful to have fortified sources or supplements for plant sterol stanols. And how does it work? It reduces intestinal cholesterol absorption, and it also upregulates the ABC, G5, and G8 genes. Okay, so, the first thing our patients will ask us when we make these recommendations is, what's in it for me? Why should I do what you're recommending? Which is, Why should I eat the diet low in saturated fat, trans fat, dietary cholesterol, lose 5% of body weight, and have 2 grams per day of either plant sterols, stenols, or 7.5 grams per day, say, of viscous fiber, or both? So here we go. So for the first one, diet low in saturated trans fats and dietary cholesterol, we would see a 5 to 10% reduction in LDL and non-HDL cholesterol. Loss of 5% of body weight, 3 to 5%. And 2 grams per day plant sterols, stenols, or 7.5 grams per day of viscous fiber, 4 to 10% reduction. So you can see the total reduction is pretty good, 12 to 25%, which is like a low to moderate grade statin. Okay, so somebody had asked me to put in a slide on calcium, so I went ahead and did that. Calcium intake and risk of CVD. So from the Office of Dietary Supplements, they came out with this professional fact sheet, which was published very recently, just last year. And again, they said that the current consensus is approach calcium supplementation with caution, as the overall body of evidence is not yet fully clear. And so they do recommend high dietary calcium intake, including food sources and supplements, are associated with lower risk of CVD. But at the same time, they have said that use of calcium supplements outside of deficiency should be avoided, with the encouragement of only dietary intake of calcium. So only if there is deficiency, then give supplements. The benefit of the use of calcium and vitamin D still remains a bit conflicting and unclear. Okay, so take-home messages. DASH, Mediterranean, plant-based healthy diet patterns can reduce CVD risk. Focus on team-based care, as we discussed with looking at all the evidence. Utilize your mental health professionals, dietitians, social workers, exercise specialists, and always consider patients' social determinants of health, including willingness and ability to make lifestyle changes and so on. Okay, now I just want to show you the clinician's lifestyle modification toolbox, because if you go to this website from the National Lipid Association, www.lipid.org, you can see you can get all these nice tear sheets. And there were 3 dietitians that were co-chairs of this project. One of them was myself, and then Carol Kirkpatrick and Julie Rolick. So we're very, very proud that our project came to fruition over the last 3 years it took us. And it's also available in other languages, as you can see here. So do check out the website. And these are just examples of these resources or tear sheets on various topics that you will find very helpful. But please don't consider these tear sheets in replacement of a dietitian. These are just to get your patient started, but do consider referring your patients to the dietitian on your healthcare team. These are references, including, as you can see, the first 5 or 6 are mine, 7, and then you can see others. So we have a great list of references for you to go to. This number 21 by Mackey is a great paper. You will really appreciate that. It's the most recent on saturated fat controversies. So with that, I would like to conclude my presentation, and I'm excited to take your questions. Let me stop sharing.
Well, thank you very much for that fascinating discussion. We're running a little late, but I had a quick question for you. How about fish and TMAO? In other words, we've always recommended.
Could you bring your mic closer? Sorry, I can't hear you clearly.
So the question was for fish and elevated TMAO. I've always recommended fish for my patients, but I never realized it increased that factor.
Yeah, very good question. And the answer to that is that it depends on if the patient has, a good microbiota, then no problem with the fish. It's just if they have a dysbiosis of their microbiota then. And I said also that, it's like we're still learning more about it, but it's like taking a picture from a moving train. But yes, I think we need to pay attention to their microbiota and make sure they're eating a lot of fruits and vegetables and whole grains and so on. For example, resveratrol, that can help to undo some of that bad microbiota, the firmicutes. We want the bacteroidetes versus the firmicutes, right? Okay, yeah.
I see that we have Dr. Jean Shadad-Puri who's come on video. Jean, did you want to ask your question?
I did,
Unmute yourself.
Geeta. I did. Thank you. It was an amazingly informative presentation. I was just wondering, for the sake of many people online, how did you find getting reimbursement for your 4-month multidisciplinary integrative program? And did you use any billing codes to get reimbursed for that?
Can you repeat the question? I'm sorry.
Sure.
I'm really having trouble hearing.
Sure. I'll try to be louder.
Yes.
I was just wondering, can you give us some tips on how did you get reimbursement for your 4-month multidisciplinary integrative cardioprotective program?
Yes.
And
excellent.
any billing codes if you used?
Yeah, excellent question. So since we are a interdisciplinary team, multidisciplinary team, our preventive cardiologists use their own codes, but they justify how much time they and we dietitians and the exercise physiologists spend with the patient. So they do bill it at the highest level. Yeah. But for dietitians, are you a dietitian or a physician or?
I'm a pediatrician.
Pediatrician. Okay. So for pediatricians, I think that would be the best, is to use your maximum codes and use your dietitians on your healthcare team. Because MNT or medical nutrition therapy, there are billing codes, but those are for dietitians specifically.
True.
And those are for diabetes and end-stage renal disease. And we have introduced a bill in Congress this year, and it was also introduced last year. We reintroduced it. And it's going to bring all the other medical diagnoses and diseases also into the billing codes for dietitians. And
that
we have
help.
the support of the American Nurses Association, the National Lipid Association, the American Heart Association. So we're hoping it will go forward sooner than later.
Well, thank you for your efforts and initiation in that direction.
Thank you.
One quick question. Do we have enough RDNs for all of these visits monthly to start people on?
The Academy of Nutrition and Dietetics has 100,000 members. So there are plenty of RDNs, more than cardiologists. How many cardiologists are there nationwide?
Probably 50, 60,000.
50, 60, yeah. So there are dietitians, and it's not bad. Once a month, I think, is doable, especially if they know they're getting 4 follow-up visits. Because if they're getting just 1 visit, it won't do much good.
That's great. So we may have some more questions that will be on chat, but we're going to switch to Major Smith right now so that we can get his presentation. And then hopefully at the end, we'll have questions that relate to sleep and diet and nutrition. So if you could show me the slide, thank you.
I'm sorry, I will be leaving. So I won't be here for the second hour. I let Hattie know ahead. So if there's
we will record any questions that come up from you, and then we'll email those to you.
Yes, please do that. I'll be happy to answer. Yes.
Well, thank you very much for your participation today.
Thank you.
Our next speaker in this great duo is Major Jeffrey Smith, who is a behavioral scientist and faculty family medicine residency at our neighbor, David Grant, down the street. Assistant professor at the Uniform Service University of Health Sciences. He's done a lot of work and a lot of presentations with publications associated with it. Currently, he is serving as the flight commander for the 92nd Operational Medical Readiness Squadron that is based out of DC. Or out of Washington, and he has been involved in numerous areas and has developed a really great program for the military and has released it. He's licensed clinical social worker, board certified in the American Board of Examiners in Clinical Social Work. We welcome Dr. Smith today to tell us about his fascinating work in sleep science.
Please unmute yourself, Dr. Smith.
All right, can you see the slides?
We see the slides and we hear you clearly.
Okay, so just real quick, I'm currently at David Grant Medical Center. I don't know, there was a little discrepancy in my bio. So I'm currently a faculty member. My previous assignment was Washington State as a flight commander, essentially a director of a mental health clinic. So I was fortunate to complete my doctorate at USC, and I recently did a defense in May on military suicide. But my passion is really looking at habits and behaviors and health outcomes, especially for the health outcomes that you're talking about on cardiovascular heart disease and other medical conditions. So really improving sleep. Sleep is a big focus area of interest and of mine. So we'll cover some of what the experts say about hours of sleep recommended per age group, sleep and its implications on performance, an in-depth review of the safety program, which is exciting. It's a model that I was able to acquire in terms of wearable technology. Some of my opportunities to actually do field work, actually taking some of these tools and doing a comparison of shift work amongst our defenders, our sleep effectiveness and consequences of poor sleep, both cognitively, psychologically, and physically. And then going over the Spielman three-factor model, which is a premise behind a lot of the cognitive behavioral therapy for insomnia, some of the treatments, some of the reviews of other behavioral intervention strategies, sleep hygiene guidelines, and how to optimize sleep and relaxation training. So both the American Academy of Sleep Medicine and Sleep Research Society recommends for optimal health of adults that we get 7 hours or more of sleep. Oftentimes when I'm asking my military counterparts what the recommendation of hours they should be getting, they're never really on par with that or think that that's a doable thing. But it's not only the duration, it's about quality, not just the quantity, free of sleep disorders, free of any type of behaviors that are contraindicated to good, adequate, solid sleep. We do not prioritize sleep as in our country, and obviously we are influenced by our technologies and some of our other events in our lives and the competing priorities. So sleep is really not where it should be in terms of our priority, and we often neglect it. So I show this table. I think this is a really good illustration, and I apply this to both military service members and our healthcare professionals. So the following figure shows the relationship between hours of sleep and cognitive performance. So reaction time, decision-making, and we can use this chart to gauge the impact of nightly sleep duration on performance. And as shown, anything less than 7 to 8 hours of sleep negatively impacts our performance. And so when we do not get 7 to 8 hours of good quality sleep, our performance decreases. And in order to ensure optimal cognitive performance, it's vital that we get that 7 to 8 hours of sleep to stay in the green. Anything less of that, we inch towards the amber zone and eventually get into the red zone. Sleep-related impairment in physicians and military is an occupational hazard associated with long and unpredictable work hours. It may contribute to that burnout and self-reported clinically significant errors amongst our physicians, our residents, and especially our military operators that are deployed forward. And numerous studies have documented the ill effects of impaired alertness associated with impaired sleep and disruptive sleep cycles. These include an increased incidence of human errors related to accidents. I'm seeing a lot of that, obviously within the healthcare system and our military system. And it increases that morbidity and mortality rates and overall decrements in social, financial, and human productivity. And right now, with the COVID pandemic, I had the opportunity to actually support some of our medical personnel back in January through March timeframe. Dr. Sky and I were deployed through Northern California for the overrun hospital. So our FEMA tasking in conjunction with the military deployed our physicians, our registered respiratory therapists, and our nursing. And as a behavioral health asset embedded in that, I was to really identify what are the trends where I could, tailor my prevention efforts. And sleep was a significant factor, not just for the nature of the long hours that they were working, but also the anxiety and the unique concepts that physicians and our other allied healthcare professionals are facing during this pandemic. So I was able to integrate a lot of sleep hygiene habits, battlefield acupuncture, auricular therapy as a behavioral health professional, implementing those to show some of the effectiveness of those on sleep. But sleep is really critical, and I can't emphasize enough how important it is to me as a behavioral health professional in working with my beneficiaries from pediatrics all the way to geriatrics, but also our war fighters and our frontline healthcare personnel. So this is the safety model, that sleep activity fatigue and task effectiveness fatigue model it's called fatigue science. And this was combined using the world's leading biomathematical fatigue model, and it was developed by Army Labs and validated by the US Department of Transportation. And we use this a lot, especially our special operators in the military are using technologies like this. And this is definitely much more sophisticated in terms of off-the-shelf products like our Fitbits and our Garmins, but it analyzes sleep data in order to accurately predict fatigue. So it captures this high-resolution data that you can get on your mobile device through the interface of a wearable. And the wearable could be it can interface with your Garmin, it can interface with your Fitbit, or shown here the products that they have. And it transmits this into the cloud. And as an administrator and clinical professional, I can see the comprehensive view of their sleep data. It doesn't track, there's no GPS or heart rate or any of those other biometrics. This is strictly looking at fatigue and predicting outcomes in terms of cognitive performance. And so using this amongst war fighters and with our healthcare professionals and my patients, I've been able to make some remarkable behavioral changes with those patients, motivating them to actually see their own data and how much that makes a difference for them to engage in behavioral change. What's nice about it too, is this is often used by the Department of Transportation with truck drivers and people that have missions that are extended. It can predict the fatigue levels, allowing schedulers, and in the case of the military, looking at service members in the predicted fatigue levels based on their sleep. So I've been able to utilize this as a SME and working with commanders to optimize their performance of their war fighters in executing the mission, but also improve good quality sleep and wellness for our service members. I've seen a lot of challenges based on sleep deprivation and musculoskeletal injuries and other problems like accidents that are plagued our military. And as the military in itself, that unique less than 1% of the population, do not value sleep. There's a cultural norm that you should be able to operate on 4 hours of sleep. You should be able to execute at an optimal level. But obviously all the data and the research shows that that's not possible. So this is this mid-day shift comparison that I did with security forces. So security forces are our largest career field in the Air Force. And their job is to do base defense, law enforcement, K-9 units. They guard our assets. Really a really critical, important job. And they carry lethal means. And when I did a comparison of a 30-day review of defenders wearing wearable technology, the fatigue science bands, you look at the difference of effectiveness in terms of functionality, sleep quality, awakenings, sleep efficiency, and then the onset variance. All these are definitely indicators that disrupt good quality sleep. But the mid-shifters definitely showed substantial impact just based on the night shift in itself, but also a lot of precipitating behaviors, health habit behaviors, changeable health habit behaviors that a lot of our defenders engage in. A lot of high caffeine concentration, supplements and energy drinks and coffee, poor diet, limited exercise, big factors that correlate onto these challenges that we have with these war fighters that are critical assets to our Air Force. And looking at this, so sleep effectiveness really is broken down into a comparison of blood alcohol concentration in terms of reaction time, functionality, decision-making, emotional regulation. And so when I showed the commander this, looking at the days, if you can see it here, about 12% of defenders on day shift had a equivalent 0.05 blood alcohol concentration versus our mid shift, nearly 40% had a 0.05 blood alcohol concentration equivalent in terms of functionality and reaction time. And considering they're carrying lethal means and executing these very high priority missions, this is huge in terms of the implications of how sleep health and plays into their functionality and ability to execute the mission, not to mention their high incident rates of musculoskeletal injuries and other behaviors that result in lost time in terms of the mission. So this is currently a snapshot of security forces unit that I'm looking at right now at Travis. And we were able to look at health and performance indicators based on an annual and quarterly self-reported periodic health assessment. So these questions are asked, and I can pull this report, eliminating any PII, but just looking at the trends. And you see here, 46% of the 247 war fighters assigned to security forces reported getting that recommended 7 hours a night of sleep. Yet 9% reported that it affects their performance. There's always a subjective understanding or misunderstanding that I'm doing much better and I can do this, but looking in that disparity. So using the wearable technologies, I've been able to really break through some of those cultural norms and make behavioral changes. It's really hard to convince young service members going against the norm that they can do more unless you have something that really shows them that their sleep is actually impacting their performance, and having them see it on their mobile device and using their wearables is important. And some of the other health habits and performance behaviors definitely correlate with the other medical readiness column here to the left, looking at musculoskeletal and mental health related problems, seeing trends in certain areas of the body where musculoskeletal injuries are more prevalent, and the mental health as well. So really, as a commander, having to deliver this and show them, this is what I'm seeing amongst your service members. I have this technology and these these skills to come in and deliver this to your war fighters. And I've been very successful at doing that at my previous assignments. So I actually took a snapshot of my own sleep last night through my Ready and Fatigue Science that's connected to my Garmin. And so generally my set bedtime is 10 and 07 is my wake time. And based on that, at 10 o'clock this morning, I was operating at 99% in terms of my sleep effectiveness, my reaction time. And what's remarkable is that based on my good quality sleep and my health habits, I've been able to maintain optimal functioning up until the waking period of my day. So seeing that 84% is really when I would slip into that amber, the yellow, and that's not until by the time I'm already asleep again. And then looking at efficiency and consistency. So this is kind of what the users see when they're wearing these fatigue sciences. Now, I know the Fitbit and Garmin and some of the other wearables do this, but this is 92% accurate against any polysomnography technology. And that's why I really endorse using this product. And I found it very effective because it really paints a picture for service members who are very difficult to influence in terms of behavioral change. So obviously consequences of poor sleep, the cognitive performance, that decreased alertness, increased risk-taking, accuracy and timing degrades, ability to integrate and learn, losing information, is easily distractible, tasks become more difficult to accomplish. I mean, this is essential for our healthcare professionals, our frontline workers, and our service members. But the implications, the psychological and social implications are huge. And we're seeing increased rates of suicide, which is a multifactorial problem, but sleep health is integrated as a big component of that. And I see these high incident rates of anxiety and depression and substance abuse in looking at some of these service members that really do not promote or adhere to good sleep habits. That emotional intelligence, working with healthcare professionals, showing that it's degraded by not taking care of their sleep health. And our social interactions decline. Obviously, we get agitated, we're more moody, but that's huge. And then looking at fitness and nutrition, and I'll speak about that increased risk of diabetes, stroke, and cancer, but that increased inflammation. You know, every cell in our body has a circadian rhythm. It's critical that we're getting that rejuvenation for our body and sleep and rest and recovery. And we're seeing a lot of musculoskeletal injuries based on just the mission in itself, but some of the sleep habit, sleep health is behind that. Our decreased sexual health, our increased desire for carbohydrates and other types of foods that are contraindicated to good health is huge. So looking at cardiovascular diseases, we know that more than 80% of the deaths from cardiovascular disease are due to heart attack and stroke. And multiple genetic, biological, behavioral, and psychosocial factors can increase this. But there's growing evidence to show that sleep problems, including inadequate sleep, either duration, short duration or long duration, or poor sleep quality, sleep disorders, or other types of sleep-related breathing disorders like obstructive sleep apnea and irregular sleep patterns, actually are associated with increased cardiovascular heart disease. Looking at strokes, when you sleep a person that sleeps 6 hours or less a night, their chances of stroke are increased 4 times. Diabetes, lack of sleep increases cortisol levels and norepinephrine associated with insulin resistance. I talked about the cognitive impairment, that high levels of behavioral health challenges. These are all factors in terms of not getting enough exercise and not being able to engage in healthy behaviors because that sleep and energy is not there. And I was looking at some research most recently, a systematic review and meta-analysis demonstrated that longitudinally associated with sleep duration and sleep quality and risk of cardiovascular heart disease. So generally, people who are sleeping not enough or sleeping too much are at higher risk. In the meta-analysis, either short duration, like less than 7 hours, or long sleep duration, 8 hours, were associated with a 13% increase risk of cardiovascular heart disease with those that are sleeping 7 to 8 hours with good quality sleep. Another meta-analysis showed that poor sleep quality was associated with a 20 to 40% increased risk of cardiovascular heart disease, and independent of sleep duration. And poor sleep quality rather than inadequate sleep duration was associated with greater morbidity and mortality of cardiovascular heart disease. I reference Dr. Walker. He wrote the book, Why We Sleep. He's got a good TED talk on sleep being our superpower. And he talks about all it takes is 1 hour. And he says every year there's a global experiment performed on 1.6 billion people 2 times a year across 70 countries. And that's daylight savings time. In spring, we lose 1 hour of sleep, which results in a 24% increase in heart attacks the following day. And in the autumn, we gain an hour and we see a 21% drop in heart attacks. It's pretty remarkable to hear those things, obviously that goes along with accidents, strokes, and other suicide actually is trending with those hours lost of sleep. And I've seen it very much amongst our healthcare workers who treat COVID-19 patients because there's a lot of fear about their own infection or infection of their patients, resulting in high anxiety and disruption in sleep. And it's that negative cascade that affects us in all different ways. And I've seen a lot of service members and other beneficiaries and healthcare professionals as a primary care behavioral health focusing on how can we optimize sleep. And generally when I'm using technology and other type of sleep behavioral change interventions, I'm seeing a significant improvement in their overall health and well-being. And I've integrated programming with our nutritionists, our physical therapy, and other allied health professionals to really improve behavioral change and improve health outcomes. So caffeine. Now, I really illustrate this here because this is more geared towards our military. I know everybody drinks coffee. Most people drink coffee or they get it from other foods, but our military personnel really rely heavily on caffeine. Not just caffeine through coffee, but energy drinks, really colorful, marketed towards war fighters that they can improve their performance. That C4 illustrated is those supplements that we often don't think about. But some of these, the Bang energy drink in particular, can have upwards of 300 plus milligrams of caffeine, which is pretty remarkable considering that 250 milligrams is the clinical cutoff for caffeine intoxication. That C4 has upwards of 300 to 400 milligrams as well. And some of these defenders and other service members are drinking 2 to 3 of these a day, which obviously is not good for your heart, but not good for your sleep and other areas. And I illustrate the Ripit on the right hand side here. This was when I was deployed to Afghanistan. I saw this being consumed by several war fighters. They would have the Ripit challenge to see how many they could drink in one sitting. And some of these have 200 to 300 milligrams of caffeine. Pretty remarkable, the impact of caffeine and how much it is affecting our sleep, but how prevalent it is amongst our military. And really, we have companies on base that market this because they know they make money off this. But this is a huge concern amongst military, but also just Americans in general. So the Spielman 3P factor model of chronic fatigue shown here, really breaks down sleep problems and insomnia based on predispositional factors, precipitating factors, and that perpetuating factors. And I think as a behavioral health professional, I'm always seeing those perpetuating factors, those behaviors that individuals engage in while attempting to manage their sleep, that are contraindicated to good, adequate sleep. And so most of the time, this is where we're having problems in terms of our sleep. Yes, predisposition and precipitating factors are there, but really getting behind those perpetuating factors. There's a lot of lack of knowledge and understanding of how critical sleep is to the body, to the mind, and the outcomes of what can happen from not getting prolonged deprivation of sleep. That myth that we can make up for sleep debt, and that's not the case. But I illustrate this here because this is really the basis behind some of my interventions as a behavioral health professional in the military. So sleep hygiene guidelines, really basic principles, but you'd be surprised. I'm integrated into the family medicine residency clinic, and I see beneficiaries with sleep problems. And when I do my analysis, my history of present illness, I look at some of their behaviors, which are oftentimes contradictory to those stimulus control procedures: going to bed only when you're sleepy, getting out of bed when you can't sleep, going in the other room, cracking a book or a magazine to induce fatigue, avoiding caffeine 6 to 8 hours before bedtime, or nicotine. Sometimes we're heavily reliant on over-the-counter sleep aids that really don't have a lot of evidence of their effectiveness. Melatonin, for example, is good for treating jet lag, but only to a degree, because if your body senses that it's getting that melatonin, it no longer needs to produce it. Therefore, there's a deprivation of that. But we oftentimes do a lot of wakeful activities in the bed, being on our iPads or our phones, having TV in our bedroom, which my wife's always trying to get me to have the TV there. I said, absolutely not. That's contraindicated to getting good, adequate sleep. But this is huge. And I oftentimes, in terms of healthcare professionals, really promoting that these are the things you need to talk about with your patients. And they're very basic, but most people do not adhere or practice these, which is very much contraindicated to getting that good, adequate sleep that we all need. So next I talk about blue light. So, blue wavelengths are the high intensity, which are beneficial during daylight hours because it boosts attention, reaction time, and mood. However, at night, it diminishes our melatonin levels and really can be impactful to us getting that good, adequate sleep. So in a Harvard research, a Harvard researcher and their colleagues conducted an experiment comparing the effects of 6.5 hours of exposure to blue light to exposure to green light of comparable brightness. And the blue light suppressed melatonin for about twice as long as the green light and shifted circadian rhythm by twice as much, 3 hours versus an hour and a half. When I'm working with a lot of our service members or even our healthcare professionals and nurses, doctors on nights, I try to get them to wear amber lenses. There's a lot of research that shows that amber lenses worn 2 to 3 hours up to bedtime can actually boost melatonin levels, and by blocking blue light and increase quality and onset of sleep. And through the research and actually application of practice, I've seen this be reported by a lot of healthcare professionals and military personnel of how much improvement just having those amber lenses can make in terms of the difference. But that's huge. And I think right now, everything's about our technology and showing the implications of how much it affects us. And a lot of the Apple products and the Androids, they have filters in their on their devices that you can use, but there's no evidence that those are actually effective. So no electronics before bedtime is key. And if you're going to use them, you're going to use them outside the bedroom. I think that's important. So although I don't encourage use of technology in the bedroom, I definitely promote and leveraging technology through to make behavioral changes. So a lot of, I speak more so on the service member because a lot of them have mobile devices. 98% of the military service has service members have a smart mobile device. There's a lot of things advertised out there on the market in terms of mobile applications, but the ones I use are really researched, empirically validated, and the CBTI Insomnia Coach put out by Stanford and National Center for PTSD and the DoD VA is a good tool that I leverage to work with patients with problems sleeping. And so it allows them to enter their sleep on a daily basis to keep a sleep journal, which is really the basis of cognitive behavioral therapy for insomnia. It has embedded relaxation tools and other psychoeducation material that can really enhance some of the practices of tools to improve behavioral change and improve sleep. And wearing the wearable technology, I take that subjective report of sleep out in terms of the sleep journal. So they just wear the watch. But in the event that they don't, this is a tool that I really promote and I use in my practice and I use myself, and I find it very effective. So really, cognitive behavioral therapy for insomnia is that gold behavioral standard for improving sleep, tackling behavioral changes, or tackling good behavioral changes to improve sleep outcomes and sleep health. Sleep aids, I really am reluctant to refer people for those sleep aids. Really want to reinforce that through behavioral change, you can make significant strides and improvement in your quality of sleep. And I've been able to get people to see that through those significant behavioral changes that make such a difference. And then addressing, obviously, the precipitating factors. Most of the time when I'm seeing people with sleep disruption, they're ruminating before bedtime. There's a lot of thought process going on, worries, maladaptive thinking patterns, really driving behavior and the emotions that disrupt sleep. So I really endorse the cognitive behavioral therapy for insomnia as definitely the way to go in terms of first treating sleep problems. And I reviewed I talked about the sleep diary and the education. I think that's huge. That psychoeducation is really critical and important and really has made a difference with me seeing a lot of my beneficiaries in practice. And then working on stimulus control training. And essentially what this is trying to decrease the ratio of time in bed versus time asleep. So oftentimes I will talk to people that might be sleeping 4 hours, but they're laying in bed at for the 8 hours. And that's, a 50% sleep effectiveness. So you really want to increase the onset of sleep to align with that time in bed, because that will ultimately result in an optimal level of sleep performance and quality. And so I often use sleep restriction as a intervention for working with people with sleep. And I always get, most of the time, 95% of the time, I have good solid sleep outcomes. And usually I'm doing this before I refer for any type of organic sleep disorders, do the Bang screening and other type of screening to assess any potential organic sleep disorders, but oftentimes it's that stimulus control and behavioral behaviors that are contraindicated that are causing the trouble with sleeping. So the relaxation training obviously is really important. That CBTI coach I showed you has these programs embedded in them that facilitate that diaphragmatic breathing, that progressive muscle relaxation. Not only do I use this for sleep, but I use it for pain and other behavioral health challenges, and that guided meditation or imagery. So in these mobile devices, they have these programs embedded in there where you listen to them. They're about 5 minutes. I usually have people listen to them with some earphones prior to bedtime, and looking at how much their sleep quality improved based on the implementation of some of these practices. It's remarkable how much we're getting increases in sleep quality and duration just by the implementation of some of these techniques prior to bedtime. And then really looking at the cognition, the thinking part of our brain. And that ABCD approach is what I generally use in my practice, looking at, we have an activator, an event that caused us to feel a certain, or resulted in a behavior, an emotion, or in how we handled a certain situation, but really getting behind some of the beliefs. So when we're working with people with the CBTI for insomnia, focusing on some of those maladaptive thoughts, behaviors, beliefs that really result in that consequence that's a contraindicated based on mood and behavior, and getting them to really look realistically and examine the accuracy of their thoughts, mitigating some of those cognitive distortions that people have in terms of life events or circumstances around them. This is a big component when we're working with people with insomnia and other sleep problems. And lastly, I really like Dr. Walker. His TED Talk, Sleep is Our Superpower, is pretty remarkable. And really he gets in depth into the implications on our health and wellness and learning and cognition, and talks about how critical it is and how yet we continue to neglect the importance of it. And so the Why We Sleep is a good read. Unlocking the Power of Sleep and Dreams, I think, is a good starting point for a lot of practitioners and just patients in general. I refer them to that quite a bit. So if you're gonna remember nothing else, obviously huge consequences, the impact of every aspect of our life, and that we can't train our body to perform in a certain way. There's always this idea that we'll make it up on the weekend, or sleep debt is a real thing. You cannot recapture sleep. Once it's lost, it's that performance illustration that I showed you in terms of that graph is it will continue, and it takes time to restart your clock. And that it's just a physiological necessity for all of us, but it's so much neglected in terms of our healthcare practices, and even working with our military service members. I can't stress enough that norm needs to be broken, because we need to operate our mission both on the front line in healthcare and with our military service members. These are my references. Definitely some good references to get into in terms of sleep. And that concludes my presentation.
Thank you very much. That was great, a great presentation. While we're looking at the chat and for some other questions, I had a quick question that has faced all of us who travel to the with a 3-hour or 6-hour time lag. How do you overcome, what do you recommend for jet lag on your part? Because you do a lot of flying too. Should you reset yourself to the new time as soon as you land there, or do you try to keep some of your old time changes with you when you first land?
Mm-hmm. Yeah, I think it's really critical to pre-plan. So that safety model that I showed you really is what the military uses to pre-plan mission. So if you know what time zone you're going to be going into, it's good to try to get on that time zone prior to departing for that. It's really important. Yes, melatonin can assist in some of those, but really that pre-planning is a good thing, because my family lives on the East Coast and I'm on the West Coast, and I pre-plan what time I'm going to go to bed to try to get on their clock. And I find that to be effective. Of course, it's going to come with some challenges, but I think just prioritizing that planning, especially for our military and our healthcare professionals in terms of shift work, and really pre-planning that to try to optimize and get on a good circadian rhythm when you're on that new change in sleep schedule.
Perfect. And I'm going to check some of the chat, but do you believe that we should still have daylight savings, or should we just drop it?
I think we should drop it just to hear some of the impacts of that. I mean, just to hear 1 hour lost of sleep, there's a 25% increase in heart attacks, and accidents and suicides. So it's remarkable how much that behavioral, that change in time can impact our health and wellness. But yeah, I think we should scrap it. That's just my opinion, though.
So until we do scrap it, how do you suggest we prepare for it to reduce the health impact? So is it like you have to start shifting by 15 minutes, or what do you do?
I generally pre-plan like a week out, so I'm gradually kind of inching into that. So I'm not, because I know people just go with it and how much it impact. You come in on that day where we've all lost that hour and everybody's walking around like zombies. We need to gradually work our way into it and get our body prepared. But to abruptly go into it, that's problematic. But I think, again, we don't prioritize sleep. We don't see, we know we need to get good sleep, but we don't prioritize it. It's like way down the line in terms of our priority, because we have so many, we have kids, we have job, we have all these things. You got to find a way to get it in. Not just the duration, but that quality is essential for good health and wellness.
So just looking at the questions we had, one question was for people who fall asleep, but then they wake up, what your recommendations, and I think you alluded a little to leaving the bedroom and going out and doing some other reading activity or something to try to readjust yourself to sleep.
Yeah.
Go
ahead.
What would you recommend?
Yeah, those stimulus control procedures, we call them, is essential. So if you can't get to sleep within 15, because what happens is if you're laying in bed and you can't get to sleep, I ask patients, I ask healthcare professionals, what are you doing? I'm looking at my alarm clock. I'm thinking about, I need to get to sleep or I'm not going to get the stuff done. You're activating your body. Your body doesn't need to be activated with sleep. It's a conditional response. That bedroom is sleep and intimacy only. It should be that sacred place. So if you can't get to sleep within 15 minutes, you get up and you go to the other room. You don't turn on the TV, you don't get on your phone, but you might do some light reading or something, not a lot of mental effort that might induce that fatigue and then go back to sleep. I think what's also important is that sleep restriction. A lot of people will get anxiety when I promote that, hey, I want you to move your bedtime back. And they're like, well, I thought you said 7 hours, but it's not about duration at that point. It's about increasing that quality. If your sleep efficiency rating is less than 85%, then that's problematic, meaning like, you're laying in bed and you're activated, you're ruminating, you're thinking. Now the bed is not associated with that sleep. So it's really critical that you're using those stimulus control procedures. You're doing some relaxation techniques. I oftentimes, we always have an agenda in our head of what do we have to accomplish tomorrow? What's going on during the day? You get a notebook, you write it down, you put it on paper, you put it to the side. It's almost like a mental, you're eliminating or you're emptying your mental box so that you can focus on getting to sleep. And those relaxation techniques are also critical. And I've seen people report, I was able to stay asleep and I feel refreshed in the morning.
Another quick
Super
question
helpful.
is
I just want to say
personal.
that
Do you actually wear your watch to bed? And if you do, is that watch available to the general public?
Yeah. So I know sometimes people are like wearing my watch to bed. Now, a lot of the off-the-shelf products like Apple and Android and our Garmin, and they all have some technology built in. And I really encourage people to use that. Not to say some people don't like, it's sometimes uncomfortable, but the reason why I wear mine, I'm all about the numbers. I like to look at my watch tracks my sleep, it tracks my stress level, it tracks a body battery, how much I'm rejuvenated. It's got all these, measures in them. Accuracy, maybe not the best, but they're enough to really guide my behavior. So yeah, a lot of the stuff is available. That fatigue science program is really more of a commercial product that I was able to get 16 accounts. They're $595 per the lifetime of the software, because it's just so advanced and using that safety biomathematical fatigue model. But the other technologies I really encourage people to leverage their devices.
I see that we have a question in the chat from one of our Los Angeles co-chairs, Dr. Keith Emmons, the medical director for SenCal Health in Santa Barbara. And he says, when you must change work shifts, what is the best way forward or backwards? And does having partial team shifts better? I'm not quite understanding, but I think he's saying, please give us practical advice when we know we have to change our sleep schedule, which is challenging for night owls like me.
Yeah, I know they talked about the clockwise rotation, counterclockwise or clockwise rotating shifts, and I have it right here. Sometimes they encourage a clockwise rotation in terms of shift change. I know what I did, to use an example, I was working with airfield operations, and they worked a 07 to 1900 hour shift, so 7 p.m. And so what we did was we used the fatigue science to track their sleep and their effectiveness and their self-report. And based on that data and based on some of that guidance, we moved their shift back 2 hours. So they would start at 05 and release at 1700. And the subjective experience of that, although they weren't too pleased with waking up earlier, they definitely felt it was much better because they had more time with family at the evening hour too. And they also, in conjunction with that, the quality and the sleep duration improved greatly just by those 2 hours of change in that. So in that case, it was, going backwards. So I find that to be effective, for some people, depending on, we have junior service members that don't have families versus those that do, but the consensus and just the data showed that change in 2 hours made a difference in terms of their sleep effectiveness and improvements. I don't know if that was helpful to kind of give you an example of something that's applicable.
I think some more practical tips are great. So we have Peter Spitzer, one of our regular participants, asking about techniques to fall asleep and stay asleep to maximize sleep efficiency.
Yeah, and I showed you the relaxation techniques earlier. So that diaphragmatic breathing, that progressive muscle relaxation, so it focuses on the calm reminders. The CALM acronym is chest, arms, legs, mouth. That's where we carry a lot of our tension. So that progressive muscle relaxation is you're flexing your muscles, you're feeling the tension, you're breathing at the same time, you're doing that deep diaphragmatic breathing. You're saying to yourself, calm, you're focused on the breath, you're focused on the muscle tension, and then you're relaxing it. So that's a very effective tool that I've shown, that's really shown to be effective, one in research, but also with my patients, seeing that they are showing not only reporting improvement, but looking at the data that when they wore a wearable device, because sometimes it's hard to get them to buy in of how these can be effective. Oh, breathing, but it's diaphragmatic breathing and it's progressive muscle relaxation. When I show them that, your sleep effectiveness improved 5 points, and your quality and duration and your awakenings per night decreased substantially just by practicing that 5 to 10 minute exercise every night before bedtime, that really resonates with them. And then they now implement that on a regular. So that diaphragmatic breathing, progressive muscle relaxation, and that guided meditation. We can always visualize something awful and stressful, and that's oftentimes what we're doing. We're not thinking about that serene, nice place that put us at ease. And guided meditation really is an exercise that activates the senses. You put yourself in, like the application has a beach scene, and the woman describes in the program a beach scene, and you activate your senses, what you smell, what you feel, what you taste, what you hear. Activating those senses really shuts off some of those other negative thoughts or the racing thoughts, and it really lowers our physiological arousal, making us much more ready to go to sleep. And so I really, all the research and data shows these are effective, not just for tackling depression, anxiety, stress, and other type of problems, but these also can be used wakeful in terms of enhancing performance.
I heard you say something earlier about writing things down, and I certainly found that to be a very effective tool. Is if some work thought pops into my head, which it often happens, I keep a notepad next to my bed and I scribble down that thing so I know it'll still be there in the morning, instead of thinking, get up and put it in your calendar or whatever. That is very good, to just like set it aside and just tell yourself office hours start at 8 or whatever.
Yeah, it's a simple tool, but it makes a difference, because oftentimes we are holding all those things inside. We're ruminating, before bedtime's the quiet time that we're thinking a lot. It's just, we think a lot about what we have to do. So I often see that delayed sleep onset as a result of some of those the ruminating thoughts. And then in terms of people waking up in the middle, they get to sleep, but then they wake up, I often look at playing with their sleep onset time to allow them to get more suitable sleep, better quality, and then titrate it back as time goes on, so that they get that good solid 7 hours of sleep.
Another question in the Q&A section is the wearable device that you created in the military generally available?
It is. For the purchase that I had to do, it had to be it couldn't be an individual buyer purchase. It was more contractual. But there's a lot of technology on the market. They have there's a ring that you can get. The reason why I chose Fatigue Science is because I encountered it at one of my bases. One of the aerospace physiologists was using it. It's a tool that really, a tool to mitigate accidents and really improve performance and planning, but I'm using it in a clinical capacity, which generally it's not always used in that way, because it's not diagnosing sleep disorders, but I can make inferences by the data I'm collecting to identify what are the challenges that this member might be having, this patient. So, but yeah, they're very available out in the community. I purchased the one from the Fatigue Science. I got a grant to get that money because it's something that the military has used, especially our special operators. And our aerospace physiologist uses a system where he has to hand jam all that safety data to get a prediction. Whereas he saw this wearable device and I had him wear it. And he's like, this is amazing. He's the SME for fatigue and surveillance and accidents and plan. He was like, this is
What's
awesome.
SME? Specialist? What's SME?
Subject matter expert, sorry, acronym. So I like the wearable. I found it to be very effective, and some of the programs, the interdisciplinary programs that I've been a part of, integrating sleep health as part of that through wearables seems to be a popular way at getting at behaviors amongst our young beneficiaries.
And there are ubiquitously available commercial devices. And as I mentioned in our pre-call time, I've found that when I exercise in a particular way by swimming for a long distance, I really lower my resting heart rate for about 24 hours. And that's when I get my deepest sleep. And I would just encourage everyone to monitor their resting heart rate and determine what it is that helps them have a very positive resting heart rate. Can you talk about that, Major Smith?
In terms of, I just was giving my personal account where, fitness is a vital component of readiness in the military, and every service has a physical fitness test. And that test by service is comprised of different types of things. But in the Air Force, it's a 1.5 mile run at your fastest pace. And it and also incorporates strength training. So 1 minute of push-ups and 1 minute of sit-ups. And then they measure your BMI, your abdominal circumference. They used to make that a point component, but that has since been eliminated. But so when I was trained, keeping up with good health habits and behaviors, a lot of our service members train for their physical fitness tests, which is not where they should be. But when I was preparing for my fitness test, my resting heart rate was down, considerably, in the 50, 60 area. And, based on my overuse syndrome, because I have a tendency to overdo it sometimes, I had to take a break, and then my resting heart rate gradually increased, to like 65, 70. So just seeing the difference in, how that exercise exertion makes a difference in those cardiovascular, heart rate and stress level and all that, I think is really important.
We had a great presentation before yours on nutrition, and yours is on sleep. You talked about the fact that avoid certain things like caffeine and caffeinated things 6 hours before. We're headed towards a holiday, and it's called Thanksgiving. And I've always been impressed with eating turkey seems to make people sleepier. Is there any evidence that tryptophan in turkey might be promoting sleep in individuals?
I have heard different things about that. I'm not an expert on the nutritional component, but I just think in nature, what do we do when we're at a Thanksgiving dinner? We're gorging ourselves, which inherently is going to result in some of that fatigue and sleep. And then, we get our nap in, and then we're back in eating mode again. And then it's like a cycle. But and I don't really have a lot of knowledge on terms of the nutrition for sleep. I know that oftentimes people that eat late at night will have greater disruption. So, a glass of milk or something light prior to bedtime can help. But obviously, I don't have a lot of knowledge in terms of the types of food that reinforce sleep. But
So I want to just say that although we don't have Geeta Sikand with us anymore, Dr. Joe Sky has previously presented very compelling evidence about the plant-based diet, about fish as being cardioprotective, and we've had many, many presentations with regard to that. I wonder, we will have a future presentation that elaborates further on TMAO, whatever that is. It wasn't described, unfortunately. But are there any dietary things that you would recommend for sleep?
I think I wouldn't say anything in particular because I'm not a total subject matter expert in that, but I think that obviously our nutritional choices are going to influence our outcomes in terms of good quality sleep. So I know working with Dr. Sky, he's big on plant-based diets, and our lifestyle medicine practice kind of goes hand in hand in terms of those type of foods and good quality sleep. A lot of the other sugary foods and high saturated fats obviously can cause gastrointestinal challenges, and then that's disruptive to sleep. So I really, that the greens and the fruits really important in plant-based nutrition, because I've really been practicing within the scope of lifestyle medicine, which one of the tenets of that program is that plant-based diet, in terms of its interface with sleep health, physical health, stress, and such.
So I learned from 23andMe something that never made sense to me, but now it really has helped my sleep quality, and I'll just share it with others in case it might help theirs. And that is that there are people who are fast caffeine metabolizers, and there are people who are slow caffeine metabolizers. So for me, I cannot have coffee after 9 o'clock in the morning and expect to sleep well that night because I'm a slow caffeine metabolizer. It stays with me a very long time. So maybe that will help some of your patients. Do you find that, do you do any genetic work related to sleep?
No, but just looking at some of the research and some of the science behind caffeine consumption, caffeine blocks is adenosine?
Adenosine.
Yeah, adenosine receptors, which
Right.
is sleep promoting, and that it produces in the brain during our waking hours, and that adenosine in the brain is there longer that we're awake, but that it builds up and then we become sleepy. But caffeine blocks this process, so it actually is contraindicated to getting good sleep. So it's not even just the consumption, because I'll have people tell me, one of my commanders, like, I drink 5 cups of pots of coffee a day and I sleep like a baby. And then I slapped the fatigue science band on him, and his sleep duration was there, but his sleep effectiveness was absolutely horrid. And he was like, it really is like, okay, let me try this. Let me, take my caffeine intake back, and saw a complete difference in his sleep effectiveness, but also the way he felt. So it took me that type, the data to show him why I think drinking 5 pots of coffee is not going to get you to the sleep that you need. But everybody has a different sensitivity to it, and I don't demonize it. It's just oftentimes people who are drinking it 6 to 8 hours before bedtime are better off than those people that have like a cup of coffee with their dinner. It's contraindicated to actually getting good quality sleep. It's a stimulant, and we rely heavily on those type of things to get us through, but sometimes we rely too heavily on it. And so I don't demonize it. I think it's a good, it's healthy and it's a good tool, but to a degree.
noticed in your slides that your military participants have very high rates of fitness in terms of exercise and lower on almost everything else. Can you talk about timing of exercise and sleep?
Yeah, so oftentimes I'll talk to service members about when they're working out. There's some that are all about the gym. They're there, they'll take a pre-workout supplement. Sometimes they'll eat it. Sometimes they think eating pre-workout supplements will give them the better push. But oftentimes they're doing these workouts before bedtime, really to accommodate their shift, or they're doing it after duty if they're on a day shift. And so you add that exercise, which you'd think would be helpful to improving sleep, but it's all about timing. So they'll exercise after duty. They'll take a pre-workout supplement, not all, but a good majority, especially the populations that we see are not good with health behaviors. And so they got caffeine in them of 300 to 400 milligram concentration plus working out, and then they say they can't sleep. So I think the timing is essential. So working out in the morning, if you're on a day shift, is more ideal, and no exercise 2 to 3 hours before bedtime. Even longer than that, I would encourage that the exercise be in the morning or a time before you actually are getting ready for the day. It actually sets you up for a better day versus those that try to work out at night, because they're oftentimes fatigued, and musculoskeletal injuries, inflammation are more prevalent in those that exercise later or before bedtime versus waking up during the morning.
Well, I want to thank you for a very excellent and comprehensive presentation. We're all into sleep. It's something that we all need to do, and we probably neglect it because of our busy lives. But taking time out to actually think about it, plan on it. I like your idea of thinking ahead of when you may need sleep and arranging your schedule rather than just reactive might be a better approach in preparation for that. And certainly we can do a lot of objective things to improve our sleep, and which will literally, hopefully, improve our cognitive ability and help all of us be more effective in our daily efforts and jobs. So thank you very much for joining us. Without any further questions in the scale, Hattie, do you have any final questions for Major Smith?
I just really appreciated the presentation. I thought the relationship between sleep and cardiovascular events, stroke, diabetes, absolutely fascinating, completely underappreciated in our healthcare teams. It really needs to be part of our standard kind of health tune-up, sleep tune-up as well. I do want to just invite you to be with us as often as it works for you. We meet every second Monday of the month and every last Tuesday of the month. Our next presentation will be on the last Tuesday in October from 4 to 6 p.m. And we'll be hearing from Mark Jaffe, who is a superman at Kaiser, super famous internationally, about the intersection between diabetes and cardiovascular health. And we'll also be hearing from two leaders of the William Sansom Diabetes Research Institute about innovative strategies for really preventing diabetes and also improving diabetes outcomes. So I hope that if you're not able to join us because of your busy work schedule and your family schedule, that you might tune into some of our recordings. We do record all of our sessions. We post all of our slides for the public benefit on rightcare.berkeley.edu. And with that, I want to thank Dr. Joe Skye, who couldn't be with us today, for introducing us to you, Major Smith. And thank you for your wonderful research and work with our airmen and women around the world, and for sharing your knowledge with our group to adopt best practices. So with that, everyone, thank you, and good health